Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast series is to bring you short, educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment in the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job of caring for people living with dementia and connecting them and their care partners to the things they need. Hello, everyone. I'm really pleased to be joined by my colleague, Dr. Charles Windon, who's going to go over with us some of the information we already went over in our webinar in February, but really now focused on the implications for diagnostics and treatment of some of the disparities that we know exist. And as you may have seen in our February webinar, we really focused on disparities across the board, but also particularly implications for Black adults. So really, really excited to talk to Charles today, and I'll let him say a little bit more and introduce himself in terms of his work and what he is focused on.
Thanks so much, Anna, for the kind welcome, and thank you for just the space to be able to participate. My name is Charles Windon. I'm one of the assistant professors at the University of California, San Francisco, and here I'm a behavioral neurologist where I participate in the clinical care of individuals who have Alzheimer's, dementia, other neurodegenerative diseases. I also do research really focused around biomarkers of Alzheimer's disease and how different social determinants of health influence risk of essentially disease and influence these biomarkers. And then I also do quite a bit of community outreach and education, trying to educate individuals in the community about brain aging, Alzheimer's disease, diagnostics, and new therapies that we have available as well.
Okay, well, you sound like you have a lot to share. Really excited and really like bringing the bench to, we used to say bedside, but now it's community side. It's, senior housing side. I know you're always in the community kind of directly working with older adults. And thank you so much, Charles. I think first off, something you mentioned in the webinar that would be really great to go over is the IDEAS study, which you introduced, and sort of why that study is occurring and sort of what the findings or hoped for findings are. So would you be willing to tell us a little bit about the IDEAS study?
Sure. So IDEAS was a very interesting effort. IDEAS stands for Imaging Dementia Evidence for Amyloid Scanning. And what the study set out to do was the study set out to understand in a clinical setting. So if you were to go to the doctor's office and essentially talk with the doctor about some memory and thinking problems that you were experiencing, in this clinical setting, what impact does having an amyloid PET scan have on clinical management? An amyloid PET scan is a special type of basically CAT scan that allows you to visualize Alzheimer's pathology in the brain. And so this study examined more than 500 different dementia specialist practices across the US to better understand when providers have access to this information, this PET scan, how does it actually affect their management? We know there's a discordance between actually clinician assessment and these biomarkers where clinicians aren't 100% accurate. Many times clinicians may assume that there is underlying Alzheimer's pathology in the brain that's causing symptoms, but that's not actually the case when you do the biomarker test. And so the study showed very clearly that having access to this biomarker test does make a difference in terms of clinical management. And again, that there's this discordance between what providers think might be causing symptoms and what is actually going on within the brain itself that's leading to problems.
I have a very basic question. Is this PET amyloid scan is considered a biomarker test?
Yes. Yeah. So when we think about biomarker tests for Alzheimer's disease, the thought process in the field has changed a lot around this, where prior to basically the creation of these tests, we went by clinical judgment. So the doctor would assess and the doctor would, to the best of his or her ability, say, I think there's Alzheimer's pathology in the brain that's causing problems. We wouldn't actually be able to tell, though, until somebody had passed away and undergone an autopsy. we now have new ways of detecting Alzheimer's changes in the brain, including blood tests, cerebral spinal fluid tests, and then what I focus on in particular, which is PET imaging. So actually being able to visualize through a special type of CAT scan where amyloid proteins and Alzheimer's pathology is in the brain.
So that's a pretty remarkable study. And so what have we learned, I guess, or do we know something about how this information is being used differently or applied differently across groups?
Sure. So one of the things that came up that was interesting, the study itself was again designed to understand changes in clinical management across the board for everybody coming into a clinical setting. But when you look closer at the data and some of the secondary analyses we have done, you start to see that there are actually differences in rates of Alzheimer's pathology between different racial and ethnic groups. So for example, in the study, African American individuals, Latino individuals, Asian American individuals, they actually had lower rates of amyloid PET positivity, suggesting lower rates of actual Alzheimer's pathology compared to non-Latino white individuals. This was despite the fact that African American and Latino individuals in particular had much higher rates of dementia in the study. And so again, we see this discordance where individuals who are African American, Latino, they have more severe symptoms, they have more severe cognitive impairment, but there's potentially less actual Alzheimer's pathology there, which raises the question, of course, well, what is causing then the cognitive impairment among these individuals? Why is there this big gap between what the biomarkers are showing and what the actual clinical symptoms are? They should be ideally the same. They should be linked together. And so that's what some of my research is really focused on. And it has really important implications for how we manage individuals clinically and the kinds of therapies that we ultimately recommend as well.
It's time for you to answer your own question because you asked it so beautifully. Like, what do we know about the biology of these differences? And maybe like clinically, is there a way to think about it that's useful? Yeah, would love to hear more.
So if we think about the possibility that there are essentially among these groups of individuals lower rates of Alzheimer's pathology despite having greater clinical impairment, we have to think about mechanisms. We have to think about potentially why. I think it's really critical to emphasize, and this was brought up a little bit in the webinar, the idea that when we think about race and ethnicity in the United States, these are social constructs with no biological basis. There's no biological basis to being Black or African American. There's no biological basis to being Latino. Human genetic diversity, when we understand, is clinal. And so you have to think beyond this idea of, well, there must be some change in biology just based on race. We know that's not the case. What it comes down to is that we know that there are differences in terms of social determinants of health. So where we work, where we live, where we play. And these differences are very clear between different racial and ethnic groups in the United States because of the history of the US. And so, unfortunately, Black and African American, Latino individuals more often are exposed to adverse social determinants of health. So, less favorable living situations, less favorable neighborhood environments, et cetera, et cetera. And because of this greater exposure, that often translates into actual changes in biology. So, that's where we see the mechanism in terms of the change in biology. It's the social determinants of health. And so, when we get back to the idea of the Alzheimer's disease biomarkers, there's a couple of thoughts. One thought is potentially, well, there may be lower rates of Alzheimer's pathology among these diverse groups, but because of the adverse social determinants of health, these adverse social determinants of health are driving a different type of pathology, specifically something like cerebrovascular disease or non-Alzheimer's pathology, so that you can have much more cerebrovascular disease as somebody from one of these groups that's driven again by these social determinants of health, and that's why you have greater impairment. There's some interesting research that has come out recently that suggests that may not be the whole story, actually. There's also suggestion that having these adverse social determinants of health maybe doesn't increase your rate of, say, something like cerebrovascular disease, but it lowers your brain's resilience to Alzheimer's pathology. So even if you have less Alzheimer's pathology overall, the brain is less resilient, it's less tough. And because of that, you need less basically pathology to get over the threshold where you start to actually have symptoms and start to have problems. It's still an area where there's a lot of exploration that's needed, but that's some of the unpacking, I think, of kind of the mechanisms and the thoughts behind why we might see these differences and what explains them.
So I always want to be sure to bring it back to the clinic. I think this is where we're all hoping to do better and to offer people better access, better treatment over a lifetime. And so one thought I'm having is sort of what are the implications for some of these findings for our practice, or any tips you can give us now? And I'll just once again express my gratitude. During the webinar, you were really thoughtful and great about connecting it back to what we're hoping to do, which is improve early detection overall and screening. And just that if we're applying this general concept of screening for earlier detection, or at least earlier detection of some symptoms, that we can really hopefully start, at least we have a starting place to address some disparities. But now with this information that some of our biomarkers, or some of now I think we're thinking about access to treatments based on pathology, which is a new way to think about folks that we're treating that have dementia. What sort of implications for clinical practice? And if you don't mention it, I'll ask you again later, like even really early on, are there ways that, so for those of us in primary care or more general fields?
Yeah, so I think from a clinical standpoint, we really do start to think about what are the implications for therapies. So we briefly mentioned this during the webinar as well, but the idea of we actually have disease modifying therapies that are now FDA approved that are available in a clinical setting. What we know about these disease modifying therapies, though, is that they're only effective really when symptoms are more mild, when symptoms are less severe. And so there's this overwhelming emphasis on early diagnosis and really early intervention. When we think about the biomarkers in and of themselves, and this is not kind of a far-fetched idea, but it's the idea that we will get to a point where the primary care doctors will actually be ordering these biomarkers. Specifically, they will likely be ordering the blood tests, which are essentially kind of the very initial screen that you can do from a biomarker standpoint. So I do believe in the future we will get to a point where, as a primary care provider, an individual would actually be ordering a biomarker test for Alzheimer's disease. Some of the interpretation nuances and things like that, of course, you may need to rely upon a specialist for, but again, primary care doctors being the first line in terms of actually screening individuals. And so screening somebody and understanding what the biomarkers mean and why there might be differences in the biomarkers is going to be critically important when thinking about referrals to therapy. So hypothetically, you could think of it in this way. You could think of it, say I'm a primary care provider, I'm ordering one of these blood tests as a screening test basically for Alzheimer's disease, and the blood test is, say, marginal, or it's in the gray zone. It's not an overwhelming positive, it's not an overwhelming negative. Again, you may need to rely upon a specialist for some advice, but in that scenario, you could think potentially about, oh, maybe this individual is from a diverse group. There are these different social determinants of health, which may be driving other pathology and lowering brain resilience. So maybe this gray level is still very significant for this person. And now is the window of intervention before they actually become more severe, as opposed to, not having that thought process and not having that knowledge. We wait around, we don't refer, and then ultimately the person, they miss their therapy window, whereby they become more severe symptom-wise, and they actually won't benefit from therapies any longer. And so I think our pipeline in terms of how we get people ultimately to therapy, it's going to intimately involve primary care. And that day is coming, I think, much sooner than many people are realizing or anticipating. And we have to start to think about, what does this test mean for the person who's sitting in front of me, depending on their lifetime exposure of different social determinants, their racial and ethnic identity, et cetera, et cetera.
Yeah. Any like work coming up that you want to plug, or that you think we should all be looking out for? Or
Yeah, so I can mention the New Ideas study.
okay,
So
that's a good circle.
yeah, New Ideas is basically Ideas 2, where they just enrich for diverse recruitment and enrollment. But they also collected more in-depth social determinants of health, and they actually
Mm,
collected plasma samples too. And so some
mm.
of the preliminary analyses for that data are being done now with hopes of being able to share that to the scientific community soon. But it's the largest study of its kind in terms of amyloid PET biomarker data for diverse groups. There's no other study size-wise that is close.
You've given us a lot to think about how we're going to use these new pieces of information, particularly around biomarkers, and how we're going to contextualize that in our, with our patients. And I just want to repeat back what I think I heard as a generalist, which is we really want to be thoughtful about, we're going to have more and more access to these tests and biomarkers. And we just simply want to be thoughtful, particularly when people are mild, about getting some additional input and possibly connecting to treatments and specialists who might be able to determine. Would you say that that's roughly accurate? And is there any, do you see coming down the line, like essentially, racial and ethnic guidelines for, based on racial and ethnic background? Or is it going to be more, we talked a lot with Dr. Tanisha Hill-Jarrett about like background, actual quality of education, not just level of education and things like that. So yeah, I'm really interested in your thoughts on, one, if I sort of have that right, and two, if you think you see a future for those sort of guidelines, or where is the field right now in terms of figuring that out?
Yeah, I think you're spot on with how you kind of summarize. I think the question of what is coming in the future is interesting, particularly with regards to, the idea of cutoffs, and how to kind of define a positive test versus a negative test. So I think we're at a critical point in terms of the science and as a scientific community where we have to do better science to start to address this. I think some of the things that we have done historically with regards to determining cutoffs, et cetera, based on racial and ethnic groups, again, they reinforce this idea of shared biology based on a social construct, which we have to move away from. We know that is not the case. And so I think when we look at these biomarkers and their cutoffs, again, we understand for any clinical disease, every clinical disease occurs along a continuum. There's no arbitrary cutoff per se in a clinical disease, although, we, from a scientific standpoint, create these cutoffs because they're helpful for our conceptualization. But when you're talking about Alzheimer's and dementia, again, it's a continuum of changes that is happening. So whatever test you're getting is going to be reflective of that continuum. There will always be essentially some level of a cutoff that basically is kind of superimposed onto the test, because otherwise it's very difficult to interpret, right? But I think the idea of having racial or ethnic cutoffs, again, we have to be very careful with. I think we're better off having cutoffs based on, say, lifestyle or based on, say, social determinants of health. So if I have somebody, and I'm interested in actually this in particular, this is some of the research I'm trying to push currently. If I have somebody who's sitting in front of me who is Black or African American, grew up in the southeastern US during the 1940s, had 6 years of we'll call it formal schooling, whatever you want to call that, in the 1940s in the southeastern US, had X number of years of kind of perceived discrimination, X number of years of internal stress, X number of kind of unfavorable encounters with, say, a systemic kind of issue in terms of housing discrimination, et cetera, there would be some algorithm or some way to compile all of that information together to be able to use it in the context of one of these tests, to be able to determine, okay, well, this person has a borderline test score, but based on all of these other things, the test score is actually corrected to, a highly positive, basically, test score. So that is my hope of where we might be able to get ultimately in terms of some of these biomarkers, where they're capturing and they're considering so much more than historically what we have actually considered.
Yeah, and it kind of underscores just how complex the brain is compared to other organs, and how detecting disease in the brain is sort of an understanding what normal is or what baseline should be, is just way more complicated than some other organ-based conditions. So what's next? Any other studies or future research that's worth knowing about?
Yeah, so I think one of the most exciting things that is going to hopefully be coming out to the scientific community in the near future is actually the findings from the New Ideas study. So we've been talking a lot about the original Ideas study, but there was basically a second rendition of ideas called the New Ideas study, where there was enrichment actually for individuals from diverse communities. So there was a very aggressive recruitment effort actually for individuals from African American and Latino communities into the study. The study was set up the same way in that it was a study of real world clinical practice, understanding how does having access to a beta amyloid PET scan actually affect clinical management. It just finished up a couple of months ago. It is the largest study today inclusive of diverse populations with amyloid PET scan, actually. So it's a tremendous accomplishment. And I think some of the results that we're going to see from it really will be illuminating in terms of better understanding some of these biomarker differences, understanding how does having access to an amyloid PET scan influence clinical management in more diverse settings. The New Ideas study also collected more social determinants of health data. It collected data on things like midlife, late life income, and it also collected plasma data. So we're actually able to use some of that plasma data to look more in depth at some of these biomarkers of Alzheimer's disease that I've mentioned.
Okay, that sounds very useful. And so it's just wrapping up.
It just stopped enrolling March.
Okay, I know we'll all be looking for the findings on that. Well, thank you so much. I think that was incredibly illuminating and a lot to think about. I'm really keep putting this in context of, if we're really hoping and asking people to screen early, where do we go from there? And if we're incorporating biomarkers into screening, it sounds like there's as much to think about, where do we go from there? How do we make sure people get access to the right therapies, the right treatments above and beyond sort of general brain health? So yeah, any last thoughts?
No, I mean, I think that's really where we're moving. It's exciting, but the same way that we do things like PSA, et cetera, which providers are so familiar with and so familiar with the algorithm in terms of how to address that, we're moving in that direction for really Alzheimer's and dementia as well. And it's a challenge because we don't have the pipelines established, and there's so much, I think, just misunderstanding and kind of lack of information about cognition and brain health that it's going to challenge us really as a medical community to figure out, we're going to have to think about how do we do this the right way and how do we really serve all the individuals who are going to need help.
Well, thank you for helping us understand more. And it's always amazing to learn from you and to work with you. So thank you so much, Charles.
Sure.
Thank you for listening and to our wonderful guests. And thank you to Lisa Costello, our audio editor and voice specialist. We want to make sure you can get CE, CME, and MOC credits by going to our website, clicking through to the podcast page, and answering a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of our Dementia Care Aware team. If you want to learn more, please visit our website, dementiacareaware.org.